Referred otalgia. Referred otalgia is the sensation of ear pain originating from a source outside the ear. The general ear region is sensorily innervated via 4 cranial nerves and 2 spinal segments. The sensory innervation of the ear is served by the auriculotemporal branch of the 5th cranial nerve, the 1st and 2nd cervical nerves, the Jacobson's branch of the glossopharyngeal nerve, the Arnold's branch of the vagus, and the Ramsay-Hunt branch of the facial nerve. Neuroanatomically, the sensation of otalgia is thought to center in the spinal tract nucleus of the 5th nerve. Not surprisingly, fibers from cranial nerves 5th, 7th, 9th and 10th and cervical nerves 1 and 2 have been found to enter this spinal tract nucleus, caudally near the medulla. Hence, noxious stimulation of any branch of the aforementioned nerves may be interpreted as otalgia. Parts of the body innervated by these neural pathways may refer pain to the ear. These general pathways are via the trigeminal nerve. Rarely, trigeminal neuralgia can cause otalgia. Oral cavity carcinomas can also be referred to the ear via this pathway. Via the facial nerve, 7th nerve. This can come from the teeth, most commonly the upper molars, when it will be worse when drinking cold fluids. The temporomandibular joint due to its close relation to the ear canal or the parotid gland. Via the glossopharyngeal nerve, the 9th nerve. This comes from the oropharynx and can be due to pharyngitis or tonsillitis, or to carcinoma of the oropharynx, namely base of tongue, soft palate, pharyngeal wall and tonsils. And lastly, via the vagus nerve. This can arise from the laryngopharynx in carcinoma of this area or from the esophagus as in gastroesophageal reflux disease. Finally, the 2nd and the 3rd spinal segments, namely C2 and C3. Let us now in detail study the various nerves that innervate the general area of the ear, the areas from where they carry impulses from, and the disease states that causes referred pain. Number 1. The auriculotemporal nerve. The auriculotemporal nerve, which is a branch of the mandibular division of the 5th nerve, and the meningeal nerve, which is a branch of the maxillary division of the 5th nerve. The parts of the ear innervated by this nerve include the tragus, anterior auricle, anterior wall of the external canal, and anterior portion of the lateral tympanic membrane. The organs from which referred pain via the distribution of this nerve may arise include the temporomandibular joint, dentition, face, mastoid, and anterior 2/3 of the tongue. And the pathologies to be considered here include TM joint disease, dental disease, trigeminal neuralgia, mandibular osteomyelitis, and parotid infections or parotid tumors. The postauricular nerve. The posterior auricular nerve, which is part of the tympanic plexus and the chorda tympani branch, and an unnamed branch currently now known as the Ramsay-Hunt branch of facial nerve 7. This innervates the posterior wall of the external auditory canal, posterior lateral surface of the tympanic membrane, and posterior skin of the auricle. In this, we need to consider vestibular schwannomas and herpes zoster affecting the facial nerve. The Jacobson's nerve. The Jacobson's nerve and part of the tympanic plexus innervate the middle, the upper eustachian tube, and medial surface of the tympanic membrane. These carry impulses from the nasal cavity, nasopharynx, paranasal sinuses, palatine tonsils, tonsillar fossa, soft palate, oropharynx, posterior third of the tongue, and infratemporal fossa. Diseases to be considered include sinusitis, tonsillitis, pharyngitis, pharyngeal tumor, glossopharyngeal neuromas. In a series, it was found that 3% of patients with a primary complaint of otalgia had a malignant tumor in the infratemporal fossa. The Arnold's nerve. The Arnold's nerve, which is the auricular branch of the 10th nerve. That is the inferior branch of the Arnold's nerve, which is the auricular branch of the 10th nerve. And impulses are carried from the inferior and posterior aspects of the external auditory canal, concavity of the concha, and lateral surface of the tympanic membrane. The areas from which impulses come from include thyroid, infratemporal fossa, hypopharynx, larynx, trachea, esophagus, lung, and abdominal viscera. The following can irritate the superior division of the laryngeal nerve, that is a branch of the 10th, and be referred to the ear. These are gastroesophageal reflux, cricopharyngeal spasms, and vagal stimulators. The other conditions to be considered include thyroiditis, thyroid tumor, and laryngeal carcinoma. Finally, we have the great auricular nerve. The great auricular nerve, that is C2 and C3, and the lesser occipital nerve C3 roots of the cervical plexus. Areas supplied include the posterior auricle and skin overlying the mastoid bone and parotid gland. Impulses are carried from the cervical spine, and disease to be considered include cervical spine degenerative disease, namely osteoarthritis, cervical facet disease, spondylosis, disc herniation, and spinal stenosis. Other conditions to be considered are whiplash, cervical meningiomas, Arnold type 1, vascular lesions, fibromyalgia, and cervical nerve root cysts. This picture shows the general areas where the nerve supply happens. We see the cervical roots, 2nd and 3rd, the 7th nerve, the 8th nerve, the 9th nerve, and the 10th.